The title of this talk is CNS malformations resulting from the persistence of remnants of transient embryological structures. These are the class objectives. You do not need to read them. They will be addressed during the course of this talk. This talk will be conducted using a question and answer format. As we have previously mentioned, nervous system congenital malformations can be arbitrarily categorized into one of 5 major types. Those that occur as a consequence of persistence of remnants of transient structures, closure failure, cleavage failure, formation defects, and histogenesis errors. This talk is about persistence of remnant of transient structures. The first question is: chordomas are uncommon malignant tumors of the axial skeleton that originate from the embryonic remnants of the A. primitive streak, B. notochord, C. neuroenteric canal, D. Ranke's pouch epithelium. When development goes well in the normal embryo, we find the following sequential events. After inducing the neural plate, the notochord becomes surrounded by sclerotomes that will go on to form the bones of the base of the brain and the vertebral column. I will use the diagram in this frame to explain the normal notochordal development in the vertebral column and make reference to the base of the brain when appropriate. So, as indicated here, most of the sclerotome tissue forms the vertebra. The notochord disappears in this region as it does when surrounded by bone tissue at the base of the brain. Hence, the vertebrae and the bones at the base of the brain do not normally contain remnants of the notochord. The rest of the sclerotome tissue in the vertebral column becomes the annulus fibrosus of the intervertebral discs. The intervertebral discs contain some of the notochord. The notochord, that is the remnants of the notochord, is normally restricted to the center of the intervertebral disc and forms the nucleus pulposus. The structure, according to some authors, is present till adulthood. According to others, it disappears by 11 years of age. What about when things go wrong? When the remnants of the notochord persist at the base of the brain or anywhere in the vertebral columns, the cells in it may multiply and produce a tumor. These tumors can occur anywhere in the neuroaxis from the base of the brain, as you can see indicated here, to the coccygeal region, as you can see now indicated. These tumors are called chordomas. The clinical manifestations of chordoma develop slowly and are related to compression of neighboring structures. Hence, they range from signs of cranial nerve involvement and brainstem dysfunction to signs of caudal equina involvement and conus medullaris compression. So the answer to this question is B. Next question. The lower sacral and coccygeal spinal cord segments develop from the caudal eminence. A true, B false. At 26 days of gestation, at the time the posterior neuropore is about to close, a mass of undifferentiated cells can be seen close to the caudal end of the neural tube. This mass is called the caudal eminence. In this figure, the caudal eminence is represented in bright blue. You can also see in this figure a yellow structure and a light blue structure. The yellow structure is the neural tube. The light blue structure represents the embryonic spinal vertebra. By 28 days, due to a process of canalization and retrogressive differentiation called secondary neurulation, the caudal eminence approaches the caudal end of the neural tube. This approximation takes place once the posterior neural pore is closed. Few days later, a segment of the caudal eminence attaches to the neural tube, and from this segment emerges the lower sacral and coccygeal spinal cord. And another segment joins the caudal end of the primitive lower vertebrae to form the lower sacral and coccygeal vertebrae. These two segments are bound by a band of embryological tissue that will become the filium terminalis. By 36 days, this process, the integration of the caudal eminence to the neural tube and to the adjacent bony structure is complete. And the connection between the two masses, the filium terminalis, becomes very thin. So the answer to this question is true. Next question. The position of the tip of the conus of the spinal cord normally rises after birth. A, true. B, false. The tip of the spinal conus in adults is at about the level of the first lumbar vertebra, as represented in this frame. The broken line in this figure represents the level of the coccygeal bones. The blue line just added represents the filium terminalis. The filium terminalis is a thin strand of fibrous tissue extending from the apex of the conus to the coccyx. The filium terminalis is made of pia mater enveloped in dura. At birth, in full-term neonates, the tip of the conus may normally be as low as the top half of the third lumbar vertebra, as represented in this newly added figure. But before birth, at 20 weeks gestation, the tip of the conus is at the level of the first coccygeal vertebra, and before that, at 8 weeks gestational age, the tip of the conus is at the level of the 10th coccygeal vertebra. So, as you can see here, highlighted by the green line, the tip of the conus rises in relation to the vertebrate bodies during prenatal and postnatal life. In my experience, by 52 weeks from conception, the tip of the conus is normally no lower than the first lumbar vertebra. So the answer to this question is A. Next question. A tethered cord is the consequence of a failure of primary neurulation. A, true. B, false. This frame depicts one of the consequences of failure of secondary neurulation, implying a failure of the caudal eminence to normal involution. If the caudal eminence fails to involucre, the thick filium terminalis, here represented by the dark blue structure, remains thick and strongly attached to the coccygeal vertebra and the conus of the spine, thus preventing the conus of the spine to move rostally. That is, rostral migration of the conus of the spine will not occur. Manifestations of tethered cord are age-specific. Severe tethering early on can produce foot and leg length and size discrepancies. and also delay milestones. In older patients, we tend to find leg weakness, back pain, and scoliosis. Rarely, in children and adults, we may find voiding and stooling problems. So the answer to this question is B. Next question. Secondary neurulation problems can present as low-lying spinal dystrophism. A true, B false. In the process of answering this question, we will address two types of low-lying dystrophism due to abnormal development of the caudal eminence. The first one is a low-lying myrocystocele. Low-lying myrocystocele are characterized by a large lumbosacral mass, as you can see in this frame. I have now added a sagittal T2 sequence in order for you to see the abnormality using this technique. The MRI shows a large subcutaneous lumbosacral mass of fat tissue and the actual myrocystocele attached to the subcutaneous fat. The second type of low-lying dystrophism due to abnormality of the caudal eminence development is referred to as a sacral dimple. Sacral dimples often manifest as a hole. Sacral dimples are often close to the intergluteal folds and often associated to interspinal masses and tether cord. Patients with sacral dimples can be studied by ultrasound if the dimple is detected at or before 3 months of age, when ultrasound can still penetrate bone tissue. You can see in this ultrasound of a patient with a sacral dimple the low position of the tip of the conus and a mass. Notice the level of S1 in relation to the tip of the conus and the mass. The two types of dystrophism we have just talked about, sacral myrocystocele and sacral dimple, are, as you can see, associated to tether cord. So the answer to this question is A. Next question. What is your diagnosis? A. Persistence of remnants of a primitive streak. B. Neuroenteric cyst. C. Persistent of remnants of the notochord. D. Meningocele. Early, on gestational age day 14, the embryonic disc amniotic surface constituted by a single layer of cells called epiblast is smooth. Late on the same day, a bulge appears close to the stalk leading to the placenta. Very late on the same day, the bulge takes the form of a narrow ridge with a thick base and a midline groove. These newly formed structures constitute the primitive streak. Thus, at this stage, the primitive streak is formed by the primitive ridge flanking the primitive groove. The primitive streak is an epiblastic structure involved in the formation of mesoderm. In these photographs, the primitive streak is represented by the dark line with the slight raised edges, as you can see indicated by the arrow. On day 15, at the rostral end of the primitive streak, a group of epiblastic cells multiply, forming a node. This node is called the primitive node or Hansen's node. Shortly after, a pit appears at the center of the node. This pit is called the primitive pit, and its appearance coincides with the beginning of the formation of the notochord and subsequent formation of the neural tube. When all goes well, we will encounter the following events. This is an schematic representation of the normal evolution of the primitive streak. On day 15, the primitive streak presents as a caudal cylindral mass with a thick base and the primitive node and primitive pit rostally. By 18 days, the primitive streak has become a thin cylindrical mass and starts regressing. And on the same day, the notochord originated from the primitive pit, as we previously mentioned, is beginning to induce the formation of the neural plate. Then the primitive streak loses its attachment to the caudal end of the embryo and shortens as if being pushed by the growth of the notochord and the neural plate. By day 26, the primitive streak is gone. When things go badly, on the other hand, the course is rather different. At 15 days, the primitive streak looks normal. But at day 18, the primitive streak fails to thin out. On day 21, the primitive streak is still thick and remains present on day 26 as a thick mass close to the caudal end of the embryo. This mass grows with time, producing a tumor in the caudal-most part of the embryo. This is an intrauterine MRI of a patient with persistence of the remnants of the primitive streak. You can see an abnormal mass. Compare it with the size of the fetus leg. After birth, you can better appreciate the size of the mass in relation to the leg. This is another view of the mass. Here, the tumor is exposed. Histological studies confirm that it was a sacrococcygeal teratoma. Here is a post-surgical photograph. Clinical manifestations of sacrococcygeal teratomas relate to local compression of neighboring structures. So the answer to this question is A. Next question. The neuroenteric canal disappears on gestational age day A23, B40, C35, D30. This embryonic disc appearance corresponds to a 15 to 18 days gestational age embryo. For the sake of our discussion, we will assign to it day 16. In this disc, I will point out 4 structures: the primitive groove, flanked by the primitive streak, the primitive node, and the primitive pit. A cut at the level shown just above the primitive pit, followed by separating the cutted piece as represented here, and by twisting the cut section so we be able to see the inner region of the disc. The inner region of the disc is constituted, as we know, by 3 layers, as it is characteristic of a 3-week embryo. If instead of cutting transversely, as we did, we do a midline cut, separate the halves, disregard the cut half, and then we twist the remaining half, we will still see the 3-layer structure, as you can see represented in this frame. Here I am indicating to the connecting stalk. We can also see the mesoderm, endoderm, and ectoderm. I will now change the position of the figure as indicated by the arrow. In this new position, the three-layer structure is placed horizontally. I am now pointing to the ectoderm, or amniotic facing layer. Structures that develop from the ectoderm are the epidermis, nail, hair, and epidermal receptors, but not the dermis. The nervous system, including the adrenal gland medulla, the pineal and pituitary gland epithelium, the cornea and lens, and to the enamel. I will also point out the endoderm and the mesoderm in this frame. Now I want to guide your attention to the primitive node and the primitive pit. It is at this stage that the walls of the primitive pit thickens, initiating the formation of the notochordal process. And the endoderm close to the notochordal process disappears, creating a canal between the amniotic and the yolk sacs. This channel is called the neuroenteric canal. Then the notochordal process burrows rostally and simultaneously the endoderm under the notochordal process disappears, creating a wide opening. But shortly after, the endodermal tissue regrowth and closes the opening. At first, the notochordal process keeps its connection with the amniotic fluid through the primitive pit. But then, the connection is lost as the pit is closed by the overgrowth of ectoderm. Once the connection is closed and the notochordal process is no longer hollow, the notochordal process changes name and then it is called the notochord. This is the state present on day 23. In the process of answering the next question, I will illustrate a different angle of this process that will allow me to provide you with a more visually clear explanation. So the answer to this question is A. Next question. Which of the following conditions is not due to the persistence of a normally transient embryological structure? A. Tetracord. B. Neuroenteric malformations. C. Sacrococcygeal teratoma. D. Spina bifida. This is another schematic representation of an 18-day-old embryonic disc. I will now label some structures relevant to our discussion. The endoderm in yellow, the mesoderm in red, and in blue, the ectoderm. The structure in violet is the notochordal process. I am now pointing to the primitive node and the primitive pit. The area I am pointing to now is the neuroenteric canal with its wide opening to the yolk sac. Please notice the relation between the neuroenteric canal and the other structures. Notice the relation existing at different levels. Close to the primitive pit, the notochordal process is hollow and surrounded by mesoderm. A little more rostally, the lower part of the notochordal process fuses with the neighboring endoderm. More rostally, the endoderm below the notochordal process is gone, but the endoderm starts encroaching the neuroenteric canal opening as indicated in this diagram. A bit more rostally, the notochordal process no longer is in contact with the yolk sac. And at the most rostral cut, you can see that the structure is no longer hollow. So this is at 18 days. But by the 23rd day, the notochordal has substituted the notochordal process in all areas, and no longer there is a neuroenteric canal. But when this process does not go well, things are different. As we mentioned, at 18 days, the enteric canal has a wide opening to the yolk sac. But by 23rd day, the canal is sealed. When this process is interrupted, a neuroenteric fistula may form, or in other occasions, when there is an overgrowth of the endoderm, cyst may form with or without connections between the ectoderm and the endoderm. So the answer to this question is D. Next question. Please take a look at these figures and read the statements below. 30-year-old, flank pain, what is your diagnosis? A, neuroenteric cyst. B, neuroenteric fistula. C, bronchocarcinoma. Persistence of the neuroenteric canal or adjacent related tissue may produce many different pathologies. Here, I will point out 3 different pathologies. One occurs when the endoderm opening of the primitive pit does not close, producing a neuroenteric fistula, as indicated in this frame. The endodermal opening of the primitive pit not closing produces a neuroenteric fistula which may communicate the CNS with a number of organs and predispose to meningitis. Often, the meningitis tend to be recurrent. This paper describes one such case. Here, the fistula communicated with the vagina. The second pathology I would like to mention is due to an overgrowth of endoderm towards the area of the neuroenteric canal and lack of timely involution of the endoderm tissue, as indicated in this frame. In such cases, neuroenteric cysts will occur. I will now say a few words about the presentation of neuroenteric cysts. The patient in this case presented was a 30-year-old man with flank pain. The chest X-ray showed a mass, better appreciated in the MRI, that when resected was a neuroenteric cyst. This is another case. A cyst was detected by intrauterine ultrasound. At birth, the patient presented with arm weakness characterized by elbow weakness and inability to extend the fingers. Also at birth, a cervical spine X-ray done showed significant abnormalities. This was followed by an MRI, and in the MRI, you can appreciate, in addition to the vertebral abnormalities, the fact that there is a large cyst compressing the brachial plexus. The cyst was exposed during surgery, which histology proved to be a neuroenteric cyst. These cases emphasize the variety of clinical manifestation and age of presentation of neuroenteric cysts. The third neuroenteric pathology I will mention is one that occurs when an overgrowth of the endoderm occupies an area of the neuroenteric canal and prevents the ectodermic closing of the primitive pit, as indicated here. In such cases, a neuroenteric cyst appeared that communicates with the skin, as you can see in this MRI of the spine. Notice the communication indicated by the arrow. So the answer to this question is A. Next question. Which of the following condition is more likely to present as recurrent meningitis? A. Tethered cord. B. Neuroenteric malformations. C. Sacrococcygeal teratoma. D. Spinal bifida. In the next few frames, I will represent some of the spectrum of pathology that occur as a consequence of enteric remnants. I will start by introducing a representation of a normal spine in relation to the skin and the enteric structures. Here I am pointing to the enteric mucosa, the enteric wall, vertebra, epidural space, subarachnoid space, and spinal cord. I will now keep this figure of a normal spine in the corner so you can compare it with some of the malformations that can occur as a consequence of enteric remnants. The figure just introduced corresponds to a dorsal ventral enteric fistula. It is called a dorsoventral enteric fistula because there are openings that communicate the skin dorsal to the vertebra with the internal cavities ventral to the vertebrae. It is called enteric because the connection is usually lined by enteric epithelium. This abnormality is often associated with split cord syndrome. At the end of this talk, I will show you an MRI of a patient with split cord syndrome and say a few words about this condition. In this figurine I just introduced, the remnants of the enteric mucosa is dorsal to the spine, and there is also a fistula connecting to the skin. Hence, the term dorsal enteric fistula is used. If no skin fistula is present, as you can see here, we talk about dorsal enteric cyst. In this drawing, we have placed the remnants of the enteric mucosa just below the skin, so we talk about subcutaneous dorsal enteric cyst. In this new figurine, the enteric remnants is located intradurally but extramedullary. Hence, we talk about intradural dorsal enteric cyst. If the enteric remnants is inside the medulla of the spine, as you can see here, we talk about medullary enteric cyst. If the enteric cyst is ventral to the vertebra, as represented in this new figure, we talk about ventral enteric cyst. If there is an opening of the enteric remnants to the ventral cavity, then we refer to them as ventral enteric fistula. I will now show you some MRI of patients with abnormalities due to enteric remnants. This image corresponds to a condition produced by enteric remnants not present in the previously cartoonish representation of malformations due to enteric remnants. So, I have now introduced a drawing that provides a pictorial representation of the abnormality. Please use previous descriptions to interpret this drawing. It is important to remember that malformations due to enteric remnants can be a cause of recurrent meningitis if the malformation has a communication between the skin, the sinus or internal cavity, and the central nervous system. In this new frame, you can see a neuroenteric cyst at the base of the brain and a second one at the thoracic spine. This MRI shows an split cord syndrome. Patients with this condition may present as adults or children. Split cord syndrome may be symptomatic or asymptomatic. When symptomatic, the presentation is usually a sensory motor deficit in the legs. So the answer to this question is B. Next question. Papillary craniopharyngiomas arise from the transformation into tumor cells of cells from the craniopharyngeal duct. A true, B false. Since 2021, adamantinomatosis craniopharyngiomas and papillary craniopharyngiomas are considered two separate entities. Both are relatively benign neoplasms that typically arise in the suprasellar or sellar region. I will first address adamantinomatosis craniopharyngiomas. This frame shows an adamantinomatosis craniopharyngioma. This tumor is due to a neoplastic transformation of cells in the craniopharyngeal duct. The craniopharyngeal duct is a transient embryological structure that is no longer present at birth. This tumor is more common in children than in adults. This tumor is often cystic, and calcification and keratin are usually present in the tumor. The term adamantinomatosis originates from a Greek word meaning hard. Hence, it is the relatively hard consistency of this tumor due to the presence of calcium and keratin that gave rise to the currently used terminology. The cells in this tumor have a bad mutation on the beta-catenin gene. Histologically, adamantinomatosis craniopharyngiomas have a very well-defined epithelial border. The epithelium forms a peripheral palisading and also nodular whorls, as you can see in this frame. We also find areas of pale microcytic-like structure termed stellate reticulum and pale eosinophilic wet keratin nodules. This concludes our discussion regarding adamantinomatosis craniopharyngioma. I will now say a few words about papillary craniopharyngiomas. This tumor is not considered as arising from an embryological remnants, as the other type of craniopharyngioma is. This is an MRI of a patient with a papillary craniopharyngioma. Papillary craniopharyngiomas are caused by a change in cell type of cells in the anterior pituitary gland. They are more frequent in adults than in children. Yet statistically, since adamantinomatosis craniopharyngiomas are more frequent than papillary ones, an adult presenting with a craniopharyngioma is more likely to have an adamantinomatosis craniopharyngioma than a papillary one. Usually, papillary craniopharyngiomas are not cystic, and they are not associated with calcification or keratin. tumor cells often have a bad BRAF mutation. The B is used because this gene belongs to the second family of oncogene discovered. The RAF is an acronym for rapidly accelerated fibrosarcoma. This is the name given to a protein found in rapidly growing fibrosarcomas. So the answer to this question is B. Thank you very much for your attention.